Hi there, and welcome to Plantar Plate Imaging. My name is Dr. Marlena Jabara, and I'm a board certified MSK podiatric radiologist. Let's take a look at part one, normal plantar plate anatomy. Our objectives together will be to review the clinical context of plantar plate imaging. We're going to discuss anatomic considerations in forefoot biomechanics, with a gross review of anatomy of the plantar plate. I'll provide you with an overview of normal MRI anatomy of our plantar plate and a normal MRI video case example, and we'll follow that with a review of plantar plate literature. So this is the type of medial toe crossover that we're looking to avoid in early plantar plate imaging and accurate diagnosis. By assessing the plantar plate at a stage earlier than the one seen here, we can prevent these gross malalignments that we can see in forefoot imaging. So what's happened here is that there's been a plantar plate tear at the second MTP joint, usually on the lateral or fibular side of the plantar plate. And you can see that that has rotated, and now we have a crossover of the second to the first toe. This can cause a host of issues, including pressure and ulcers from the crossover of the second to the first toe, and that's a serious consideration in our diabetic patient population. Let's take a look at how we begin, which is usually with our x-rays. So when we're looking at our x-rays, we really want to take a look at the lateral, where we can see a flexion deformity as seen here at the PIP joint, and that's called a hammer toe deformity. In addition, we can see the beginning on the frontal view of a medial toe crossover, where the skin of the second toe is beginning to come close to the first. And of course, looking at sesamoid rotation can give us a look at where we begin to have our greatest momentum of toe off. So as we shift the sesamoids over towards the fibular side, we can see that we're losing our sweet spot of the hallux MTP joint at our greatest point of toe off, and it's beginning to slide towards using the second MTP as additional toe off strength. X-rays can also tell us a lot about biomechanics when we look at our 3-view series. So after we've looked for our standard fractures and whether or not we have malalignments, including looking at the base of the second relative to the middle cuneiform to assess our Lisfranc injuries, we can begin to see other changes in bones that may tell us about biomechanical stressors, including what's seen here, which is this cortical thickening seen at the second metatarsal. In addition, notice it's slightly bowed. And so there have been changes perhaps in the biomechanics related to how we heel strike, move to the mid-tarsal region, move between early and late flat foot phase of gait, eventually to toe off, and the additional changes in the metatarsal alignment at the bases that can be seen when we need increased ground reactive forces to help us propel the patient from supination into pronation to toe off. And we can see what can happen as a hammer toe deformity as we begin to have second plantar plate tears. We can begin to wear out the plantar plate, creating a situation where we begin to have a hyperextension at that articulation and a resultant hammer toe deformity compensatory at the PIP joint. Furthermore, we can see that the forefoot in this case is beginning to spread out, where we have this overlap at the metatarsal bases, a situation that can be seen in metatarsus adductus or forefoot inversion. So I-inversion is where we're going to get the stacking of the metatarsals. So the additional second metatarsal stress can be seen here in this case by the cortical thickening. In other patients, we might actually see flattening of the second metatarsal head as the biomechanics of the second MTP joint is altered, creating a situation that creates accelerated osteoarthritis through our second MTP. Looking at anatomic considerations in metatarsal head size, we begin to see form and function. The first metatarsal head is responsible for a great amount of pressure experienced at the toe-off phase of gait, and it is wider rather than taller. In addition, there are sesamoids that fit into a helical articulation to help offload the great amount of forces that are experienced through the great toe during toe off. Looking at the lesser metatarsals, these are responsible for a great amount of load transfer. So they're taller rather than wider. Furthermore, looking at the first MTP joint, we have a sesamoid apparatus that is invested by the accessory collateral ligament. And that's different from the lesser metatarsals, which is the bulk of our conversation today. We're going to be taking a look, in this case, at the first MTP, which is sesamoid, the accessory collateral ligament. We have the proper collateral ligament, and that's going to adjoin some of the abductor hallucis, the muscle and the tendon, to reinforce the collateral ligament complex seen here. Furthermore, the space between the sesamoid and the base of the proximal phalanx is filled by the plantar plate at the center aspect of this articulation and on either side by the sesamoidal phalangeal ligaments. Removing the first metatarsal head, we can expose the plantar plate seen here with a star, and on either side, that's where we're seeing that sesamoid phalangeal ligament on either side of the plantar plate. Of course, the sesamoids are joined by the intersesamoidal ligament, and we can see the flexor hallucis tendon tunneling through the plantar aspect of this articulation with a fibroosseous tunnel that is extending itself towards the flexor hallucis brevis. So these are static and dynamic. The static considerations are the sesamoids and the dynamic stabilizers of the first MTP joint. Furthermore, at the first MTP joint, we have these collateral ligaments, and those are further reinforced medially with the abductor hallucis and laterally with the adductor hallucis, both the transverse head and the oblique head. Looking at the lesser MTP for anatomic considerations, we can take a view of the metatarsal and the proximal phalanx and begin to dissect away some of that anatomy. So I've drawn here the deep transverse metatarsal ligament, which forms the floor at the level of the metatarsal bases. The deep transverse metatarsal ligament meets the accessory collateral ligament at a point where they'll create a juncture at the plantar plate. So we can see that here in cross section. We have our plantar plate, and where it meets that deep transverse metatarsal ligament, that's when we have the investment of the accessory collateral ligament. Superficial to the accessory collateral ligament, we have the proper collateral ligament, and we also have the interosseous tendon coming through between these regions. So we've had the muscle moving into the tendon, and this interosseous tendon will join the lumbrical tendon past the point of the plantar plate at the MTP joint to form a further reinforcement of this oblique portion of the medial aspect or the tibial side of the plantar plate. So once again, the anatomy that we're looking at here is the plantar plate deep to the metatarsal head. We have the accessory collateral ligament, which is joined by the deep transverse metatarsal ligament at the level of the MTP joints. Furthermore, on the medial plantar aspect, we have reinforcements by the common tendons of the interosseous tendon and the lumbrical tendon reinforced on this medial tibial side. Of course, on the lateral side, we have the interosseous tendon forming further support at the juncture where the accessory collateral ligament is going to form with the deep transverse metatarsal ligament. And there's a lot of reinforcement on the curves because as the plate begins to wear out, we begin to have rotational malalignment, and there's reinforcement for that type of rotation. You can appreciate on this illustration how I've drawn in the plantar plate. It forms a hammock underneath the metatarsal phalangeal joint. So we can see that here, this whole black basket weaved underneath to support the MTP joint. Looking at the metatarsal heads in transverse, we can begin to appreciate we have those plantar plate, we have the accessory collateral ligament, and where that joins the deep transverse metatarsal ligament, we have that reinforcement. Of course, the proper and accessory collateral ligament really can't be dissected from one another in the course of reading an MRI if they're normal, because both are low signal and do not contain water. In between the articulations of, say, M2, metatarsal 2, and metatarsal 3, we have the metatarsal bursa, and that's a potential space that can become inflamed and enlarged during times where we have rotational or increased stressors at the metatarsal head. Of course, I've left out, let's just go through the entire bit of anatomy, going through the entire circular apparatus of the axial image. With our extensor digitorum longus and brevis tendon, we have our sagittal bands that keep the tendon centrally located. This blends imperceptibly to the region of where we have our proper and then our accessory collateral ligament. Of course, that again is going to blend into the region where it joins the deep transverse metatarsal ligament at the level of the metatarsal head, and then to the plantar plate we go. Of course, we have our flexor digitorum and flexor digitorum brevis tendons joined by its flexor tendon sheath. We have neurovascular bundles that are superficial to the deep transverse metatarsal ligament as seen here and here. Furthermore, I've added in our interosseous tendon and the lumbrical tendon here seen as separate decussated areas at the level of the metatarsal, and they'll join to form a common tendon band that will reinforce the medial aspect of the capsule. And of course, on the lateral aspect, we'll have that interosseous tendon that can reinforce that capsule on the fibular side. Looking at plantar plate imaging in the cadaver, which the surgeon wants to master, of course, we can dissect from the dorsal aspect of the articulation The proximal phalanx is seen in the lower part of the image, the metatarsal head seen in the upper part of the image. Once we dissect through those extensor tendons, the digitorum brevis and the longus, we get to expose the bony structure seen shiny here, exposing the capsular contents and removing the metatarsal head. We can expose the plantar plate. And the plantar plate seen here in the gross specimen to the right, we can see that shiny plantar plate, that plantar oval shaped structure that's about 2 centimeters long and about 2 millimeters in thickness. 2 to 5 millimeters is what it's been described as. And we can see on either side of the plantar plate the capsular areas of thickening. Here, the plantar plate has been drawn up for us to show us that cross-sectional thickness of about 2 to 5 millimeters. And of course, we can see for a second, I wanted to just stop and give us some inkling of what's to come in terms of the plantar plate pathology. So when tears occur at the plantar plate, it's going to be seen in early stage tears to have a transverse rent or transverse tear. So we'll be tearing medial to lateral in this case. But as the tear becomes a higher grade, 3s and 4s, we're having a longitudinal extent of tear. And that's a tear that's going to dissect along the longitudinal fibers and allow what's called buttonholing to occur, where the metatarsal head can actually penetrate through the plantar plate itself and, of course, dislocate. Plantar plate MRI protocol, just a second. I'd like to talk about using the proper field of view. In order to see the forefoot, you'd want to use a field of view that's no more than about 8 to 10 centimeters in total field of view. And of course, the slice thickness, being that we're looking at structures that are on the order of between 2 to 5 millimeters, we'd like a section thickness of about 3 millimeters and no more than that on any of the given sequences. Of course, high resolution imaging, always better for these small structures to be able to define them with clarity and accuracy. Now let's turn to the MRI. So what I've loaded up here are sagittal and transaxial images, and that's really the workhorse of defining plantar plate imaging. So we can see in this sagittal image, what I've loaded up is that you can see the plantar plate itself as this low signal band imperceptibly drawn to the flexor tendon itself. We can see some of the intermediate signal intensity at the level of the cartilage, the hyaline cartilage that divides the metatarsal head and the proximal phalangeal base. Of course, this is cortical bone, which is of lower signal intensity than the marrow element seen here, which is of slightly higher intensity, slight amount of physiologic joint fluid seen here. Looking at the transaxial image, we can see where we're looking for is a U-shaped structure as we described in our illustrations, looking from the region of the flexor tendon to the level of the plantar plate, of course, in the region of the accessory and proper collateral ligament, which we really can't dissect off of one another in the normal situation. So this is at the level of the typical rectangular shaped metatarsal head that is taller rather than wider. And here we can even see some of the attachment of the phalanx, so the plantar plate phalangeal ligament at its typical triangular shaped proximal phalangeal base. And of course, just to throw in for extra, there we can see our sesamoid complex, we can see the flexor tendon, and of course the collateral ligaments and the accessory collateral ligaments reinforced with our the beginnings of our first plantar plate complex beginning at the metatarsal side. So here's anatomic considerations at that distal attachment loaded up for us so we can see a better example of what it looks like at the attachment of the distal plantar plate phalangeal attachment seen here with low signal paired attachments on the proximal phalangeal base. I'd like to make a note about a normal plantar plate recess, which is generally thought to be no greater than 2.5 millimeters in width. So at the central aspect of the joint space, we have a normal recess that we can see from medial to lateral will seal up and become a formed attachment between the plantar plate and the proximal phalangeal base. But at the center aspect of the articulation, there is this normal recess that's usually on the order of 2.5 millimeters. And I'd like to show you now an example of a normal MRI of plantar plate imaging. Let's take a look at this example of a female 48 years old who presents with forefoot pain. In this case, I have an example of a normal plantar plate to show us. When we're looking at forefoot issues in general, we'll be looking heavily at the transaxial and the sagittal images. The sagittal images give us a great idea regarding the biomechanical alignment of the foot. at least in this position. And the axial images really help us to dissect out the individual anatomy, slice by slice and millimeter by millimeter. What I've loaded up for us here are 3 fluid-sensitive sequences, all with fat suppression. I also have one T1 weighted sequence, which is where the fat in the intramedullary canal and the subcutaneous regions are demonstrated. Looking further at these images, taking a closer look at the sagittal images, let's take a look at the second metatarsal phalangeal joint, looking at the cortical bone of the metatarsal head and the proximal phalangeal base and the fat suppression. We'll be looking to see whether or not there's any kind of stress response or fracture in these bones. Looking further, we can identify right away that plantar plate 2 centimeters long, roughly 2 millimeters in thickness, no elevated signal within the plate, at least seen here. We do see this region here consistent with a plantar plate recess. That would be no greater than 2.5 millimeter, and we can measure that here in any plane. So here, again, pretty constant at 2.5 millimeter or less. We can see the plate firmly attaching to the proximal phalangeal base as seen here. We can also appreciate the flexor tendon as it approaches the joint line, and then we'll continue on the digitorum longus, moving to the distal phalanx. Moving to the transaxial image, we can appreciate moving from proximal to distal, the U-shaped structure of the plantar plate, how it blends into the region of what will form the flaw and the deep transverse intermetatarsal ligament region. Here's your flexor tendon with its flexor tunnel, and we move into the plantar plate, moving into the region of the metatarsal head. And once we're at the point of the deep transverse intermetatarsal ligament, we can begin to consider these the accessory collateral ligaments and the proper collateral ligament. Furthermore, at the level of the deep transverse intermetatarsal ligament region, we're going to begin to form a convergence of the interosseous tendons with the proximal phalangeal base at that level. We're going to join the lumbrical tendon and form a thickening of that interosseous tendon complex here. This one is slightly thickened, and this one is more on the normal order here. But nonetheless, what that represents is a superficial reinforcement of the whole plantar complex. And many times we can see that that is either thickened or torn. So in the case of a normal plantar plate, again, what we'll be looking for is that U-shaped plantar structure, the plantar plate, blending imperceptibly with the flexor tendon. We'll be able to see the accessory and the proper collateral ligaments as a complete U-shaped structure supporting the MTP joint. We will begin to see reinforcements at the tibial side of the distal joint capsule, where the interosseous tendons of the dorsal and plantar interosseous musculature will join up and form reinforcements all along that medial side of the capsule. And that is your normal plantar plate imaging. A few more things we'll look at besides just the plate. We'll be looking at the region of the intermetatarsal bursa. We can see that again transaxially as the interosseous tendons decussate and move towards their capsular. They create a potential space that can fill as a bursa, and that's your intermetatarsal bursa. The deep transverse intermetatarsal ligament being the structure between M2 and M3. That's the terms given to metatarsals. And then superficial to that region, you can see the nerve artery vein complex. And then distal to that region, we'll begin to see further changes of the interdigital nerve. And we can see that with detail on T1. So here what you're seeing are at the level of the proximal phalangeal base, distal now you're seeing the two limbs of the nerve that have the interdigital nerve that have come together in this region here. And again, moving back into the foot, we're looking at the muscles of the dorsal and plantar interosseous musculature that are basically forming the capsular reinforcements that further support the medial plantar complex seen here. And the presence of a neuroma generally is thought to occur from friction against the deep transverse intermetatarsal ligament. So when we have a neuroma, it is felt to be a symmetric enlargement in the middle of this interspace. But a pseudoneuroma lesion, which I'll show you other examples in other videos, you'll start to see that the enlargement of the nerve moves towards one of the regions of the plantar capsule. And that's indicative that the region for the neuromatous inflammation is secondary to a plantar capsulitis. So distinguishing the type of inflammatory or perineural fibrosis that's occurring may help us to further distinguish our patients and help them find their forefoot wellness again. Thank you for your time and attention. Now let's take a look at a review of literature important to plantar plate imaging today. Whenever I'm thinking about interpreting MRI imaging, I always like to start with some idea of the biomechanics involved, and ground reactive forces is the name of the game for metatarsal and plantar plate tears. How much time we spend on the ground, how much pressure, what inclination, what degree of pressure does that metatarsal head feel will tell us something about the ability of its structures to withstand those moments, forces, and vectors. So in this case, the diagram is well laid out by Kirby that the plantar fascia contracts against the plantar plate. And if this reverse windlass mechanism is working, it should pull the toe down to the ground, and that will enable you to toe off and propel yourself forward. When I'm thinking about how to apply any of what I see, or I'm seeing a case, it always helps if I go to a site that I love. RadSource has been a great boost for education, and I think that these clinics and these small chapters that show a general case really have helped me a long way in understanding. So in this case, they give you an example of a 56-year-old female with gradual onset of forefoot pain. And you can see that this MRI through the forefoot is showing some pathology in the region of the plantar plate. As we've come to see, we can see that there's some subluxation or incongruency of the second. And we'll take a look at the findings as they explain them to us. And we can see that direct, complete discontinuity of the plantar plate here. We can see this discontinuity of the proper portion of the collateral ligament and that medial toe deviation, widening, or what's called splaying between the second and third, and they give it that diagnosis. So RadSource is wonderful, and I really think that the illustration here hits home that anatomy we talked about. If we looked at the third metatarsal head and we understood that deep to the head, there's that thickened plantar plate, relatively speaking, about 2 millimeters in thickness, about 2 centimeters in length, about 8 to 10 millimeters in width, connecting to the accessory collateral ligaments, which are invested superiorly dorsally by the proper collateral ligaments. That deep transverse intermetatarsal band separating out that region of the flexor tendon from the neurovascular bundle. So these articles and illustrations help us to understand some of the complex anatomy that we are up against when we're trying to understand how the metatarsal ground reactive forces are affecting this entire complex. Generally speaking, after reviewing this, we've seen that we're going to be looking for that U-shaped structure, looking at the flexor tendon, again, looking at the accessory and the proper collateral ligament and the collateral ligaments. I really like RadSource because it also goes to explain not only complete tears, but partial tears, which can be subtle and showing as this focal fluid intensity on stir imaging in that case. This, a complete tear of the lateral proper collateral ligament with that medial deviation, and that splay finding we'll take a look has been written up. If you see a dislocation, definitely means that you've had a plantar plate tear, and it can even be a very thin plantar plate, so you may not even see it. Again, gives you some guidance to the clinical diagnosis and management, and helps us to understand how the clinician is actually stressing this. And these features here can help us understand how we might better serve our clients and patients in ultrasound, where we're doing a lot of this dynamic imaging. In looking at some of the great original work that's done in this area, I really learned a lot from this predictive MRI correlates of lesser MTP joint tears by Ullmans and Elzinger. And this, they looked at control cases of different reasons why the forefoot would have some kind of pain. They separated all the different reasons out. They looked at patients who had plantar plate tears, and they looked at some of the features that are associated with plantar plate tears. And they did some interesting things. And I think this is biomechanically what leads us to some of the problems. And they were looking at the rotational axis of deviation. Now, if you've been in any of my classes, you hear me talk about flattening of the forefoot parabola. And there are different ways we can flatten. The metatarsal head, these lesser metatarsals, can rotate towards the great toe. And when it does that, what it's doing is a forefoot varus. So basically, it's supinating the forefoot and moving the forefoot into that varus position. Oppositely, we can see that the great toe is coming in this medial direction in a pronating stance. And so they looked very interestingly at the convergence. So they found that when the great toe, the pronation moment and the supination moment, when it was greater than 45 degrees of an axis of rotation, that was an issue that predisposed the patient to plantar plate tears. And they also looked at just this rotation, but I think they found it to be too tedious to actually measure it. But I think it's an observation that we can make, and it might be helpful for the clinician to understand that in the neutral position, when the patient's laying in neutral position in our magnet, that this is the general rotation of the axis. This might also help to explain why more commonly the tears are on the fibular side of the plantar plate complex, often affecting the interosseous membrane, the lumbrical, that whole complex, and the lateral aspect of the plate. Of course, they also talked about splaying of the toes, the second and third being a predictor, a secondary sign that you might have a real issue regarding the plantar plate. And also, again, looking at that eccentric pericapsular fibrosis. And that was one of the most important additions to the literature, the differentiation between what it meant to have a pseudoneuroma and what it meant to have an interspaced neuroma. And it's important to differentiate. They point out that it's particularly problematic as treatment varies dramatically and misdiagnosis and mistreatment can cause prolonged pain. And forefoot dysfunction is something that we encounter clinically over and over again. So I think adding to it would be to add in the MRI some of the features of what we're seeing. And I simply state this out as metatarsus adductus, or rotation of the plantar bases towards the great toe, just to give an idea. And I do talk about the forefoot parabola. Furthermore, they looked at many different indicators as to sensitivity, specificity, and accuracy of these indirect MRI features in detecting plantar plate tears. So they looked at things like dorsal subluxation, pseudoneuromas, proximal phalangeal bone marrow edema. And this is a great article out of AJR from 2017, second and third MTP plantar plate tears, Yamada and their group. Amazing work that really, I think, put plantar plate imaging on the map as something that you will find most radiologists reporting whether or not the plantar capsules are intact, and picking apart that you need excellent quality in order to see these structures. So having slice thickness of 3 and 4 millimeters, as we've talked about in the lecture, and having a smaller field of view, the field of view being on the order of 8 to 10 centimeters, and not trying to take in the entire foot, are parts of your clinical excellence and putting into your imaging so that you can get images that with clarity show the plantar plate as a structure invested into the proximal phalangeal base, looking at the flexor tendon here, the U-shaped structure, helping us to pick out where the flexor tendon and tunnel is with regards to the plantar plate, the accessory collateral ligament and the proper collateral ligament, that thinner band. Furthermore, giving us excellent demonstrations of what it meant to have this pericapsular eccentric soft tissue swelling that we can see here. If we dropped and bisected that midline, we can see that a portion of this eccentric pericapsular fibrosis is hugging this metatarsal head, and that's indicative of the pseudoneuroma sign. And we can contrast that to a neuroma where there's a central thickening of the interdigital nerve. It's still considered pericapsular fibrosis, but it's more global, and it's felt to be compression against the deep transverse intermetatarsal ligament. Furthermore, they propose a grading system that really helps us to understand that tears less than 50% partial tears, and that's very common. You'll see a lot of that. And the kinds of tears that you for sure want to pick up would be 3s and 4s, where you're certainly seeing involvement not only of the tear, but also secondary structures, now collateral ligaments, beginning to show signs of instability, right? And of course, buttonholing tears, where the metatarsal head is moving through the plantar complex. Furthermore, direct features, they outline clearly for us partial or complete discontinuity, seen in 13 out of 34 patients. Thinning, these are other signs. So thinning of the distal insertion, non-visualization of the plantar plate was something that was occasionally seen. Any change in the morphology, so morphologic changes were present in all of them. So having that sensitive eye to detect may help us to start to see these tears at all. Of course, I leave this for you to evaluate because I think everything in this article is important, including the imaging, which helps us to find this interosseous tendon thickening. This is an earlier sign that I see very common in patients who have early plantar plate dysfunction. Notice the pericapsular inflammation. In this different patient, they're showing us that plantar plate proximal phalangeal distance line. And they again talk about the association between those indirect features with plantar plated surgery. So almost all of these patients that had a pseudoneuroma sign had a plantar plate at surgery. And interosseous tendon collateral ligament complex, many of them also had that. So being able to identify these features with clarity will help us to stratify our patients. And when we look at where this becomes important, I really think that this particular chapter that puts it together for us at MR imaging of the plantar plate, that normal anatomy, turf toe, and other injuries, they go through the entire constellation of forefoot imaging. And I suggest for anyone in the business to really be picking apart this. They go through all of the anatomic features that I've started to describe, the different shapes of the metatarsal heads, the great toe being larger and the second metatarsal head being taller rather than wider, and what these features mean. And just to skip down to things like that are occurring at the lesser plates, we're looking at that crossover deformity, giving us excellent pictures clinically to help us with our MRI read to understand what we're trying to do when we're moving that classification system to help our clinicians. Again, those examples of a full dorsal dislocation. In this article, again, reviewing for us some of the features that might predispose us to plate tears at all. Having second metatarsal head protrusion may indicate that there's a greater driver of the metatarsal ground reactive forces. So things like this may predispose the patient or may be indicating that we indeed are having more pressure on a plantar plate. These are normal examples. They move to abnormal examples, this being a normal sonogram and this being the abnormal, the hypoechoic region of the tear in this area of discontinuity of the plantar plate seen on ultrasound. So they give us an idea of what we can see. But what is really the power of this article is it also brings a lot of the clinical portions home by talking about the treatment and what we can do for our patients. So where in the past they did not have great surgical techniques, now they have restoration techniques of joint function, soft tissue transfers and reconstruction that can really help stabilize these lesser MTP joints and are showing to have greater success. But what we can do is help them to understand what is the degree of dysfunction that the patient is showing on the MRI by looking at the metatarsal parabola, letting them know about the ability of a head protrusion or their goals, helping them to reduce pressure under the metatarsal head. What do we see on the MRI to help alleviate that? Does the patient have a pes cavus or different things like that? And so I think that these great articles that I presented between the original articles, Brad Source, and understanding the biomechanics really help us to hit home and impact the treatment outcomes for our patients with forefoot pain. Thank you. References available for your review. And lastly, our summary. What we've done together is we've reviewed the clinical context of plantar plate imaging. We've discussed forefoot biomechanics and had a gross review of plantar plate anatomy. We've provided an overview of normal anatomy of the plantar plate and provided a case example in video format. Lastly, we finished with review of supporting literature, and I hope you've enjoyed this first presentation on plantar plate anatomy and will join us for part 2 coming next in MRI plantar plate pathology. Thank you again.